The National Conference for Nurse Practitioners is the conference for primary and acute care clinicians. NCNP will be held March 20th through 23rd, 2020 at the Gaylord Opryland Resort Hotel in Nashville, Tennessee. This biannual event is sponsored by Wolters Kluwer, publisher of the Nurse Practitioner, and offers you educational sessions relevant to advanced clinical practice, giving you the tools you need to improve the overall quality of patient care. To register for this event, visit us online at ncnpconference.com. We hope to see you in Nashville this spring. In this episode of the Nurse Practitioner Podcast, Dr. Susanne Phillips discusses the 32nd Annual APRN Legislative Update. Can you explain how data for publication is collected?
Sure, this is a great question, and I know a lot of readers wonder how we collect this information. So briefly, we do it by survey, and surveys are sent to state boards of nursing as well as representatives from each state, nurse practitioner organization. Sometimes it's a general nursing organization if that's who is representing nurse practitioners, or an APRN organization if they are collectively represented, whichever is relevant for that state. In June of each year, we send 2 surveys out to those entities. Those surveys are returned somewhere between August and September, and I begin working on the updates to the state information at that point as they begin to trickle in. I would say our rate of return on the survey from at least one representative from each state is approximately 70%, so that's pretty good. Occasionally we get surveys from both entities, but there are many times where we do not. Within that survey, respondents are asked to review the previous year's text to verify accuracy, and then I make those necessary changes that they ask me to make. I do go through and edit for content. I eliminate outdated, irrelevant information, such as this year I took out, where it was obvious, I took out nurse practitioners can sign their own prescriptions. That was relevant 10 years ago, not relevant now because we're signing our own prescriptions. And then the final copy is sent to the publisher for copy editing. This year, 25 states made statutory or regulatory changes to either APRN practice authority, reimbursement, prescriptive authority, or in some cases, 1 or 2 of those areas that we report on. Typically, the boards of nursing report active licenses. As you can see, there's a grid with the number of active licenses in the state. Occasionally, the state nurse practitioner associations provide that information as well. For states that do not report updated numbers, and some boards of nursing do not even collect that information annually, they might do it every other year, I scour their webpage to obtain their statistics. And many boards of nursing have that listed on our webpage. Some do not at all. So we often have to make second and third requests for that information. If I'm not able to locate it and we don't get a response, then we do report it as the same as the previous year. So I think that pretty much covers it for how we collect the data for our update.
What overall nationwide trends did you discover with this year's update?
For several years now, there's been a major legislative and regulatory change around controlled substances prescribing for all prescribers. This comes from the opioid crisis, and state legislatures trying very desperately to enact reasonable statutory and regulatory changes to ensure that patients are getting appropriate care, but not being prescribed these medications inappropriately. So probably I would say for the last 4 years, it may have been even longer than that, but at least for the last 4, I've noted an uptick in the amount of states that have adopted the prescription drug monitoring programs and requirements around providers checking that system before they prescribe a narcotic or, in some cases, benzodiazepines as well. Additionally, there's been an upsurge in limitations on prescribing opioids for acute pain. And in some states, they will mandate how many pills you can prescribe, and in some states, they mandate how many days of therapy you can prescribe pretty much for acute pain. With the release of the CDC's guidelines on the treatment of chronic pain, providers have changed the way they're prescribing for patients that do have pain long term, but it's for this acute pain that we seem to have a little bit more trouble managing, and so I've noticed a lot of statutes coming down saying you can only prescribe for 5 days, or you can only prescribe a certain number of pills, or even a certain amount of morphine equivalent morphine equivalent. Also, mandatory continuing education. States are passing laws saying that any provider that prescribes controlled substances must have continuing education, in most cases, every renewal cycle, which is typically 2 years, in substance abuse disorder and opioid overdose prevention. So that continues to be the major theme this year. Of course, many states are working on full practice authority. Some are more successful than others, but certainly you see that as a major trend. Even if they're not successful, you see a lot of bills coming through with full practice authority request.
How do you see full practice authority legislation developing throughout the country?
Well, most states are working consistently with state legislatures, and by consistently, I mean many states that do not have prescriptive authority run a bill either annually or biannually. In California's case, our legislature has a 2-year cycle. So if we put it in the first year, then it may continue the second year. Some have much shorter legislative cycles. But whilst they're working consistently, the trend that I've noted and have been reporting in the update since 2013 is this inclusion of the transition to practice requirements as a key piece to successful passage of these bills. While there's no research documenting that health outcomes are improved in states with a transition to practice requirement, and in fact, the 19 states that have full practice authority without it do not have worse health outcomes. Every single bill that is passed 2013 has had this transition to practice period. I've described in previous publications of the update, there's no consistency of time or in any state. If a reader is to read it, it looks very random in terms of hours, years, those types of things. But state NP organizations have very specific political reasons why they've adopted the time frame that they have. And the time frame is anywhere from 1,000 hours to 5 years. So as you look at the update and you look at the map, you can see the great variability. But it's very clear that this is a political requirement. Certainly it's not based on any policy in terms of safety or quality. Just as a point of history, Maine was the first state to adopt a transition to practice period in 2007. They were the only state that had that until I think it was 2013 when the next state adopted it. Just a trivial pursuit question, Rhode Island was the last state to pass full practice authority without a transition to practice period.
Can you briefly describe the practice authority advancements over the past year?
Sure. The practice authority section within the update is typically the biggest section, the one that has the most updates. I recently changed the introductory article to provide the reader with a snapshot of the general categories of legislative changes, and then I provide sort of in alphabetical order, really, categories, and then within that, which states have made the changes. This year, 12 states enacted legislation or adopted regulations pertaining to practice authority in the area of collaborative practice agreement expansion, which is great for those states, scope of practice improvement and clarifications, including global signature authority. Global signature authority seems to be a consistent change from year to year. Various states adopt either complete global authority or sections of that. There have been changes this year in Board of Nursing Regulatory Authority in one state, and something that's new that I'm seeing, and it may be a trend, it may just be this year, are healthcare agency medical staff membership changes to include nurse practitioners and APRNs, and also credentialing and privileging requirements. And then finally, APRN education requirements. There are always states that are updating their current regulations to include the LACE model educational requirements for nurse practitioner programs.
Can you describe the reimbursement authority advancements over the past year?
Yes. Historically, this section of the update has had the fewest changes over time, mostly because when you're changing reimbursement authority, you're not dealing with the Nurse Practice Act typically. Typically, states are dipping into insurance code and various sections of the legal code for that state, and it is more difficult. There's also a big regulatory component to this in terms of Medicaid reimbursement, and changes to regulations in Medicare and Medicaid, most people know, take a long period of time. So Historically, this one has been, I would say, the thinnest in terms of updates. I would say that for this year, actually, there was 3 states that reported reimbursement changes, including Medicaid reimbursement for telehealth services in one state. And I will say that telehealth services is becoming more prominent in the legislature in terms of bills going through. So I think we'll see more of that in the years to come. Workers' compensation reimbursement, we saw one state improve the reimbursement for those patients. And then finally, recognition and reimbursement by accident and sickness insurance and health services plans. And that is huge, and I'll explain that just a little bit. When we as providers think about insurance reimbursement and can we be providers on a specific plan, and if we can be a provider, will they reimburse us independently or will they only reimburse the physician? There are a lot of issues surrounding reimbursement. When a state says nurse practitioners can be not only can they be reimbursed by these plans, but these plans can't prohibit them from applying and becoming preferred providers on them, that is a really big change. And we had one state this year that was successful in doing so. So you will definitely see improved access in that state because nurse practitioners will be more visible.
Finally, can you describe the prescriptive authority advancements over the past year?
This is the section that second to prescriptive authority that we see the most changes each year. Some of them are very subtle, some of them are major. When states are passing full practice authority bills, oftentimes you see a lot of changes in this space. Sometimes states pass full practice authority and then connect that transition period, which I was speaking about a little bit earlier, to the prescriptive authority piece. Sometimes it's for the entire practice. But this year, 10 states enacted just a wide variety of legislation pertaining to APRN prescribing. I mentioned before the themes regarding controlled substance prescribing and continuing education requirements around that. It's interesting and I guess refreshing that when I've seen this legislation over the past several years, it is provider neutral. Nobody's going after nurse practitioners or APRNs solely on the controlled substance restrictions. It is across the board for all prescribers. The prescription drug monitoring programs and providers being mandated to check those programs prior to prescribing opioids and or benzodiazepines, that seems to be gaining traction. And what we're seeing is, within the last couple of years, laws have passed saying, yes, you have to do this. And now we're starting to see the regulations come through that actually operationalize that program for each state. And then this year we've also seen some updates and improvements to prescriptive authority agreements and certainly the consultation and referral plans that some states require. So although maybe full practice authority hasn't been achieved in those states, there have been some improvements that make practicing a little bit easier and certainly improve access for our patients.
Do you have any closing comments?
Well, I would like the listeners to know that this article is written both for seasoned policy experts in the APRN world, as well as students and practicing providers out there. I include act numbers when legislation is passed and statutory and code references where that's applicable, so readers can refer to the original language. I know as an educator, I appreciate when I can send my students to a resource and say, okay, here's the brief synopsis of what's happened. Now go look at that code section or that act, and let's dig into it a little bit deeper. Certainly, we don't have enough space in the update to spell all of that out, but I do try to include that for those that are interested in looking at it further. The other thing I'd like to say is I do not attempt to interpret the statutes, but rather report those changes. I interpret trends, certainly, as the author, but I'm very, very much aware as a policy expert the nuances of interpretation, and so I keep that out of it. This is why we ask the Board of Nursing and the nurse practitioner organizations, respectively, to review the state updates each year before we make the changes, and let us know if something's not reported accurately, because we certainly want to be a resource that people can come to and depend on. Although I personally verify the statutory and regulatory information myself, because I'm well versed in how to do that, certainly errors is possible. So I want readers to know how this process goes. And then finally, I would like to thank the individual APRNs, certainly the educational institutions and my fellow education colleagues. There are certainly think tanks and researchers out there that utilize this information. So I try very, very hard to make sure it is as up-to-date as it can be and as accurate as possible. And really, I am honored to have the privilege of writing this update annually. So I want to thank everybody.
This podcast does not constitute medical advice and should not be taken as such, and does not replace professional judgment or advice. The ideas and viewpoints expressed in this podcast do not reflect the official position of the speakers, authors, affiliated organizations, the Nurse Practitioner Journal, or Wolters Kluwer.